Yes. Hello. Good morning. Good morning where I am. Hello, everyone. I'm pleased to welcome you today on behalf of Physicians for Human Rights. This is the 18th in our webinar series exploring the COVID-19 pandemic through the lens of health and human rights. I'm Michele Heisler, and I'm proud to serve as PHR's medical director. I'm substituting for Donna because Donna McKay, our executive director, because she is heading back from Portland, Oregon. I'm still in Portland, Oregon, where we are here investigating the use of excessive force by US government agents against demonstrators. They're, as you all have read, employing indiscriminate use of crowd control weapons such as tear gas and dangerous use of rubber bullets and other impact munitions against demonstrators. One of our esteemed panelists for today's conversation, Dr. Zaher Sahloul, powerfully reflected in a tweet that today's protests in Portland throughout these past 2 months are reminiscent of the demonstrations in Tahrir Square in Cairo and in Syria. We were all so hopeful then. PHR has investigated the abuse of power in so many countries as part of our work to hold governments accountable for human rights violations. Being in Portland this week, as people from all sectors of Portland protest in support of racial justice in the midst of this COVID-19 pandemic, things don't feel so different from oppressive use of force we have investigated elsewhere. We're here to document threats to democracy as people exercise their right to express themselves. To those live with us, thank you for joining us for a very important conversation today on the disproportionate threats of the COVID-19 pandemic on conflict-affected populations in the Middle East. A pillar of PHR's work is our research, documentation, and calls for accountability on attacks on healthcare and on healthcare workers. The populations of Iraq, Syria, and Yemen have been devastated by ongoing conflict and attacks on healthcare that are a systematic and widespread tactic of war, destroying medical facilities, killing healthcare workers, and leaving communities without care for acute or routine treatment. In Syria, we've tracked and mapped out attacks on healthcare since 2013. In Yemen, we've partnered with our esteemed colleagues at Mwatana for human rights, and I'm so glad that Radhya is here with us today to document how attacks on healthcare have decimated Yemen's health system and caused death and suffering among Yemeni civilians. In Iraq, we've been working to build forensic capacity among the legal, medical, and judicial sectors to document, analyze, and preserve evidence of war crimes and crimes against humanity. I am emboldened not only by PHR's work to hold governments responsible for human rights violations in these regions, but by the dedication of today's panelists who have all worked to demand accountability for these very and many other injustices. I'm thrilled first to introduce our moderator, Dr. Spiegel. Dr. Spiegel directs the Johns Hopkins Center for Humanitarian Health. He serves as the professor of practice in the Department of International Health at the Johns Hopkins Bloomberg School of Public Health. There he lectures and leads research on humanitarian emergencies. Dr. Spiegel is a member of the editorial board of the journal Conflict and Health. He formerly served as the deputy director of the Division of Program Support and Management at the United Nations High Commissioner for Refugees. And previously he worked as a medical coordinator with Médecins Sans Frontières and Médecins du Monde in refugee settings in Kenya and Congo, among many other roles supporting health and human rights in the global sphere. Paul, thank you for leading our conversation today, and I will now turn it over to you.
Thank you, Michelle, so much, and thank you to Physicians for Human Rights. It's a real pleasure and an honor. I have a huge amount of esteem for what PHR does, and so I'm thrilled to be here today. I'm also thrilled to have such distinguished panelists who actually aren't just pontificating, as I often do, but are actually there doing the work. And so I'm thrilled to be able to moderate this discussion. I'm not going to give many remarks at the beginning because frankly, I'd really like to hear from the panelists. The idea is that each panelist will speak between 4 to 5 or 6 minutes, one after the other, and then we will open it up for Q&A. Needless to say that in Iraq, in Yemen, in Syria, in occupied Palestinian territories, there are so many problems pre-COVID. And we're very, very interested to hear from you how COVID-19 has actually affected, and from the perceptions to how physicians and how other healthcare workers actually respond. So it's my pleasure first to introduce Radhya al-Mutawakel. Radhya is a Yemeni human rights defender who co-founded the Mwatana Organization for Human Rights. She was named to Time's 100 Most Influential People in 2019, and she's actually calling in from Yemen, I believe. So Radhya, over to you, and thank you.
Thank you, Paul. Thank you for Michelle. Thank you for all of you. I'm glad to be with you here. I am the chairperson of Mwatana for Human Rights. It's a Yemeni NGO. One of the main things that we're doing in Mwatana is documenting the violations by all parties to the conflict. We have field researchers all over Yemen, and we follow an investigative research methodology. We started to document for advocacy, and now we are documenting for advocacy and accountability too. And we also do a lot of legal support for detainees and those who are forcibly disappeared by all parties to the conflict in Yemen. So Yemen now is known as the worst humanitarian disaster in the world, but whenever I hear this word, I have the passion, or I feel it's very important to keep saying it's a man-made disaster. It's a man-made crisis. It's not a natural crisis. So what's happening in Yemen, it's happening because of the violations by all parties to the conflict. So whenever we talk about any new crisis in Yemen, like the pandemic of COVID-19, we should also remember the violations of parties to the conflict that made this pandemic even more complicated. We, with Physicians for Human Rights, we in Mwatana, published in March a report about the violations from all parties to the conflict in Yemen against the medical system in Yemen. We documented over 120 incidents where medical facilities were attacked. The categories of these incidents were airstrikes by the Saudi and Emirati-led coalition, ground attacks mainly by Houthis armed group, and also military occupation by Houthis and by the Hadi government and by other armed groups loyal to the coalition, and also assaults on health workers and other violations such as looting and restriction on humanitarian aid. And all of these attacks reported, and in the report killed at least 96 civilians and health workers. This documentation happened since 2015 until 2018, or in about 20 governorates out of 22 governorates in Yemen. This will just give us a view how the system, the healthcare system is in Yemen, even before COVID-19. It's not only in Yemen, it's not only the healthcare is collapsed, it's also the state is collapsed. And many medical workers, most of the medical workers are not paid their salaries for years. And this is the same thing with Yemenis. So people in Yemen couldn't even face cholera. And then you can imagine how was the situation with the pandemic of COVID-19. Many Yemenis were among these years have died because of a very preventable disease, which is cholera. The first case of COVID-19 was confirmed in Yemen in March. That was months after it was spread all over the world. And in spite of this, no one was ready in Yemen, not the authorities and not the people. And by then, when COVID-19 started to be more and more in Yemen, more cases, our doctors and health workers was not prepared, even with the very simple things like the masks and the suits to protect themselves. So we have lost in this battle. I mean, reports now saying it's about 97 workers, health workers. Among them, there are professionals like Dr. Amal Maher, for example. She's a professional regarding the eye surgeries, and she was visited from all over Yemen, and she was died because of COVID-19, and she's young. So we are losing our professionals who are very limited because of this. But I can't even tell you how many cases was confirmed in Yemen. There are some official statements about 1,600 and 400 was killed, but we know as Yemenis, as citizens, and normally that these numbers are not true. There was no official statements to tell us what's happening because of COVID-19, but we were surrounded by death from everywhere. Our neighbors, social media was just surrounded by news. I mean, it was covered by death news. So, and we didn't know what is happening, what are the authorities, whether in Sana'a or in Aden, are doing exactly to protect people. People started to feel scared even to go to the hospital. The idea of stigma has spread all over Yemen. A lot of deaths has happened, and Yemenis, they cannot choose to stay at home. It's whether to die from hunger or to die from coronavirus. So they have to go to the street. And most of the people, they don't even have clean water and so to protect themselves with the very easy things. So in March, April and May, the range of death was very, very high. Now it is much less, not according to the officials or authorities, it's according to the people and doctors we are talking to. We don't know why it's less, and I hope it will continue being less. But it's not the only disease we are facing. We are facing many diseases in Yemen, and we are facing all of these diseases in a very, very collapsed situation because of we are a conflict zone. And I'm sure that all people around the world, when they hear about the pandemic, they will say it's a crisis that we have to face. But people in the conflict zone, they will say, oh no, this is enough. We cannot do more. I will stop here to just let the rest for the questions, and thank you.
Thank you very much, Radhya. That was very, very powerful. The next speaker, it's my pleasure to introduce Hala Al Saraf, who is a founder and executive director of the Iraq Health Access Organization. Hala is a former Fulbright scholar and a former staff member of WHO in Iraq. So Hala, over to you, and thank you very much. You're on mute. Samantha, can you unmute? Samantha, are you able to unmute Hala?
We are working on it. Sorry for the technical difficulties, everybody. One quick second.
Oh, I think you're off. Yep.
Good, thanks. Thanks, Radhya, for the briefing, and thank you, Paul, for the introduction. Yes, so Iraq Health Access Organization is a national nonprofit NGO founded in 2007 with a vision to retrieve Iraq's once leading position in health among the EMR, the East Mediterranean region. We believe in the right of our community to access health, and with this statement that positions us wherever access to health is limited. So you often see us at a conflict zone out of frontline. That's why we called the frontline organization. We work on health and social determinants of health, We are partnering and actually representing UNFPA in these situations where access is limited. We're also partnering with International Medical Corps and Heartland Alliance, as well as others. And our focus is the vulnerable groups of Iraq. Under UNFPA funding, we are running sexual and reproductive health in more than 25 health facilities in Iraq, including 4 hospitals, which give us an inside view from inside the health facility and the health system about how things are running under the COVID and non-COVID situation. In the GBB, we are working with the UNFPA again, empower survivors through ease of management and livelihood initiatives.
Hala, if you can speak just a little bit louder, because we're having a bit of trouble hearing you. Thank you.
So when countries started reporting COVID, Iraq was very busy. The government was very busy with dealing with the demonstrations of October 2019, where youth spread in these demonstrations and they were in confrontation with the government then. So no one paid attention to the threat of the disease coming up. It wasn't until February, around mid-February, when Iraq first reported the first case of COVID to the WHO dashboard. But it was in mid-June when cases started to escalate. So coming to a question, why late reporting, whether in Yemen or in Iraq, it has to do not with the health system, but with the circumstances, the other factors that affect reporting, but they are not related to health, probably to the politics of the political situation or the circumstances of the government then. So with the reporting escalating in June, today we have reached a situation where today Iraq reported 120,000 confirmed cases in Iraq. And those are with a daily new cases of 2,800. The interesting part is that 6,500 of these cases were for cases of healthcare workers being infected with COVID-19. This is a percent of 5.5% of health workers being infected in COVID. And that's the highest, even highest than the US. So we need to question why health workers are not getting enough protection as they deliver healthcare in the government institutions. Death rate has been, Iraq reported more than 4,500 death cases. So that puts our CFR at 4%, which is higher than the region, which is 2.6, I think. It's the regional CFR for the East Mediterranean. So in terms of, do we believe this is the adequate number? We believe that it is underreporting for many factors. People are afraid to declare that they have developed COVID or they even have the symptoms. There's a strong stigma to being associated with the virus. There is also the lack of confidence in the health facility. People are not they are afraid to approach the health facility because they are afraid of getting contaminated with the disease because of lack of IPC procedures or inadequate IPC procedures. In terms of testing, Iraq has run less than 1 million tests for a population of 40 million. Percent puts it at a very low rate and among the least of the surrounding countries. And again, it is important that access to testing is only for people who wish to test, but people are afraid to approach the health facility to test. Moreover, we believe that there aren't enough health workforce to perform all these tests, and the infrastructure is not capable of accommodating that number of population. And therefore, we see that there is an underreporting in the testing and there is underreporting in the cases. And when we look at the international support for Iraq in terms of the COVID, it has been less than any response towards, for example, ISIS, where there were lots of support, or even any other humanitarian crisis that Iraq went through the past decades. And the reason why is because, again, Iraq declared itself as out of the humanitarian phase, because they announced that Iraq is going in the development phase. So once in the development phase, that cuts the international community support towards the humanitarian phase. Despite that, we see WHO is still running the technical testing and the technical coaching for COVID. UNFPA is still running the sexual reproductive health services, and other organizations are doing the same. In terms of the national capacity to respond, actually we see the religious institutions are very active in this pandemic. They already built or provided more than 10 isolating centers for the areas where the caseload is high. But one questions, who is going to work in these services? With the building capacity of the health professionals being so low, with not enough training, we are actually putting the health force at a risk of facing COVID without being well equipped to face the pandemic. The biggest challenge is in the capacity building, and those professionals are like what Radhya mentioned. Many of them, we lost them without even an official figure of how many we lost amongst health professionals. The number goes between plus 300 up to 500, and these are not official figures from the government, but from syndicates and outsiders. We would love to see the number, but definitely we see our staff mourning their professors dying for COVID, and that constrains pain for them. Social cohesion, I would admire for Iraqis. The community is standing for each other's, but that term is very limited towards like what's equivalent to the food baskets and supporting the day-to-day family. Not much is done from the government side, and I would love to see how we can continue with this challenge forward, because there are fears. Challenges of the health sector. This whole crisis is a matter of planning. Had there been adequate planning for what is needed for emergency preparedness phase, we would not be in short of lab supplies or PPEs or ventilators in the midway that puts the population under direct threat. So the challenge is for the health system, is this challenge that the whole country is facing as a fragile system. I would stop here and expect questions, and I'm willing to answer. Thank you.
Thank you, Hala. Very, very interesting, and bringing up a lot of issues of the capacities of governments to respond, and then actually the religious communities, as well as testing, which I think is obviously a major issue in all of these countries. So I'm sure we've already seen some questions. We're going to move to our last panelist, Dr. Zaher Sahloul. Thank you very much, Zaher. Zaher is a co-founder and president of Med Global, which provides healthcare services to refugees and at-risk populations in crisis areas and low-resource countries. And Med Global has just released a report actually on the impact of COVID-19 in Yemen, a very interesting report that I encourage you to read. He has extensive experience in advocating for access to care, protection of healthcare workers, and bringing medical aid to Syria. He's also one of the few that I know that is still practicing critical care specialist at the Advocate Christ Medical Center and is associate professor in clinical medicine at the University of Illinois in Chicago, where he is right now, if I'm not mistaken. Zaher, over to you.
Thank you, Paul, for the introduction, and thank you for Hala and Radhya for the remarks. They covered everything I wanted to say, actually. But thank you again for PHR for this important series and this webinar that is very timely. And Eid Mubarak, this is a holiday for many Muslims, and they're celebrating tomorrow the Eid of sacrifice. So Eid Mubarak and Kul Aam wa Antum Bikhair to my colleagues in Yemen and Iraq. I had the opportunity and the pleasure actually to visit the countries that we're talking about today, including Iraq, Yemen. I was in Yemen 4 times in the last 3 years, and of course Syria and Gaza Strip. These are countries that have long history. People are hospitable and welcoming. In spite of the challenges that they are facing for a long time, they are very resilient, including healthcare workers, some of the smartest that you've seen in the world. I practice in Chicago, and I go to practice sometimes in these countries. And I can tell you that doctors over there and nurses are much smarter than the doctors in Chicago. So that's a compliment for them. And it's very unfortunate what's happening right now with COVID. That is impacting healthcare workers in these countries in a way that is unimaginable. It is, of course, COVID has impacted healthcare workers in Italy, in Spain, in the United States. Many have died. But when you have heads of sections in Yemen or Syria or Iraq dying, it's very difficult to replace because of the shortage of healthcare providers, because of the war, because of the displacement, and also because of the disruption in higher education. So that's something that we do not have here in the West. We have medical schools, plenty of them. We have training programs, but that is not the case in Idlib. For example, in Idlib, which is in northwest of Syria, you have 1.4 physicians per 10,000 people, compared to 25 physicians per 10,000 people in the United States. So imagine if you have only few doctors or nurses in Idlib died because of COVID. In Syria, we had started to see actually the peaking of the crisis because of COVID, and that is expected to get worse in the next 2 months. I've been talking with some of my friends who are practicing in Damascus, and they are telling me horror stories. And I don't want to share all of them, but for example, that doctors are forced to buy their own PPEs because hospitals are not able to provide PPEs to doctors and nurses. That patients are required to purchase their own oxygen because hospitals are running out of oxygen. I have a few patients here in the ICU in my hospital here that if I use the same amount of oxygen in a hospital in Damascus, it will deplete the oxygen in 1 day. So lack of oxygen and shortage of oxygen is something that is is faced in Yemen, in Gaza, in Syria, in Iraq probably, but we do not face here in the West. And that, of course, one of the leading cause of mortality because of COVID. Underestimating the number of cases. When we're talking about Yemen having only 1,600 confirmed cases, this is, of course, a joke. Everyone knows that the real number is much higher than that. Just for put things into context, in Italy, we had 120 physicians who died compared to 35,000 patients who died. In Yemen, we have close to 100 physicians who died. So you can extrapolate from the numbers in Italy. If we're gonna just extrapolate, gonna be about 20,000 people in Yemen who died, not the 400 that is the that is the official number. Of course, part of the reason for that is lack of testing, and this is common in Syria. They're doing only 300 tests every day. In Gaza Strip, in the West Bank, in Yemen. So one of the main things that I would encourage the international community, especially the WHO, to provide to these countries that are suffering from the war and the catastrophes is more testing capacity, more PCR machine, and more testing kits. One of the other problems that we are facing in these countries is the logistical challenges to get the aid in. Imagine if you want to send a PCR machine to Idlib, or PCR machine to Gaza Strip, or a container of PPEs to Yemen. It takes long time. It takes a lot of challenges. Even wiring money to countries like Syria or Gaza, because of the de-risking practicing in the banks, it's very difficult to wire money to purchase PPEs and oxygen and ventilators. So these issues have to be addressed by the United Nations and the international community, especially in light of the sanctions on these countries, some of these countries, especially Syria, Iraq, and Yemen. And the last thing I would like to talk about is the stigmatizing of patients that have been hinted to by Radhya, and also stigmatizing of healthcare workers. You have now attacks on healthcare workers in Yemen, in Syria, in Sudan, in some of the other countries, because they are not able to provide care to the patients who have COVID, because that hospitals are closing the door to COVID patients in some of these countries. So the population and the families of the patients are taking their angers not at the authorities, but at the doctors and the nurses who are trying to provide care. So healthcare workers are caught between the rock and the hard place. They don't have enough PPEs to protect themselves. They do not have medications and oxygen and ventilator to provide care. And they are accused by the families of the patients that they are the reason for the death of their loved one. I would like to stop on here, and maybe we can address some of the other issues in the Q&A answer.
Great. Thanks to all of you. I'd like to encourage the participants on the Zoom to please put in your questions in Q&A, and I see there are some already. But let me start with some questions to the three of you. There are differences, but there are many similarities actually in what you've been saying for the three countries, clearly, Syria, Yemen, and Iraq. And certainly one of them appears to be the disproportionate amount of healthcare workers who are dying. Is it purely because there is a lack of equipment that is available to them? Is there a way that such equipment can be found in these countries? And are there other ways that we can try to address this situation? Because as I think as you said, Zaher, if you have so few doctors and healthcare people in Idlib and you start losing them, it's obviously every healthcare worker who dies is catastrophic. So that's one question. And then perhaps the next question is testing. And this is obviously an issue across the board in many parts of the world. But you had mentioned, I think, Radhya, that it's not just the available tests, but actually the capacity of healthcare workers to do these tests. Are you able to break it down a little bit in each of you in these three countries in terms of what are the limitations? Is it purely supply, or also is there a demand issue where even if there were a lot more tests, people may be scared to actually to get tested for obvious reasons that you discussed? So maybe first, Radhya, if I can ask you to comment.
Yes, sure. For the equipment, it's there in the market. So it's lack of administration, a lack of a state. So many NGOs, civil society, they went to the market, many people, they went to the market to buy equipments for the doctors, and they sent them to the doctors in Sana'a and Aden and Hodeidah. So it's there in the market, but the authorities, I can't even call any authority like a government or state, but the authorities did not bother themselves to buy it or to find a way to help the doctors and health workers to protect themselves. So it's a very easy thing. Even during the pandemic, the hostilities, the war, the clashes were going on. And they are each side is very perfect in doing them. They buy bombs, they buy tanks, they buy rockets, but when it comes to healthcare, they are not ready to spend money. And for the testing, there maybe, even if it was available, people, they don't want to go and test themselves. It was not the situation. They were scared. They were not testing the authorities. They were not testing even the equipment, I mean, the machine for testing people for COVID-19. So many of people, they didn't even go to the hospital. They preferred to stay at home, and they called doctors. So the doctors in Yemen, they worked in hospitals, and they worked a lot over the phone, consulting many people all over Yemen. And they do this voluntarily. So many people, they prefer to stay at home and call doctors to consult them what to do, and they don't want to go to the hospitals. And if you go to have a general test, each test will say if you have some doubt that you have corona, they will say, I have a relative that it was said in his test, coronavirus should be considered. So anyone who has any kind of disease that might be corona should act as if it is corona. This is what the Yemenis did by themselves with not going to the hospitals.
Thank you. Hala, please.
I would classify the reasons for different categories. For example, what's happening in Iraq is that the decisions that were made to supposedly make things easier turned out to make them more complicated because the decisions were not thought of, in my perception and my study as a health policy and management. It puts a question mark. For example, they did not allow, like they allow people go to purchase PPEs in the market, or they purchase oxygen because they have money, they want to save their beloved ones. But then the suppliers put the prices so high, so that brings the forces, the government forces, the security to close the factories that produces oxygen, which makes shortages more severe, which makes demand even higher, and people are not having access even if they can afford it. So neither the government is making it available nor allowing the population to buy it at a price. So that made a kind of a situation of a chaotic situation in one of the governorates where they had to bring the national forces to solve a problem. There are other issues regarding like in the attempt to control contamination, they closed private clinics. So the decision was to close all private clinics so no one can go and crowd, and social distancing is not maintained. But the malls are open. So if people can be in a mall, why cannot see healthcare in a private clinic? Because everything else is shut down in the hospitals for COVID. So these things are the consequence of taking a decision that is not very well studied, could bring a reverse situation. And therefore, I think it has brought more damage than support to the intention. In terms of planning maternity, very often we see in many of the governorates that there is no quarantine for pregnant women. Pregnant COVID women are kept in the same ward as others. So that puts a threat on other pregnant women, because this one is so that is not, there is not clear, or maybe it's in the not planned figuring out of the high curve that made the situation that people were unable to take the right decision at the right time. I would I would like to answer the question of mental health. And the question here is related to, are there enough? And very rightly said, there aren't enough mental health professionals, psychiatrists. In a governorate like Mosul, I think there are only 6. And with the size of trauma that Nineveh has been through, from the times of ISIS towards the Yazidi plight and the return of IDPs to trauma sites, there is a lot of need for psychiatry and psychologists, clinical psychologists, but there aren't enough resources. And this is something that is not going to be worked on by a decision, or it takes time to build capacity that was not planned for. Yes, definitely it affects the mental, all the surveys, Harvard, others made so many surveys that we participated in, as well as ours, and there is an escalation in suicide cases in some of governorates like Diyala. There is a number of depression increasing in this due to the lockdown, due to the cut of the economic daily, and due to the factors that there's a lot of gender-based violence. Thank you.
Thank you very much. Zaher.
So I think I'm going to address a couple of points. Mental health is very important. Burnout syndrome is very common in the United States among physicians who are seeing very sick patients in the ICU. And every physician, I would say, I've met in Gaza or Syria or Yemen had some type of burnout syndrome. So this is a crisis, an epidemic, and it's not addressed, definitely. One of the few simple things that can be addressed is by compensating these physicians who are putting their life on death every day, whether they are in Syria or Yemen, by paying them their salary and compensation for the risk that they are taking. And this is not happening. So this should be a priority. Talking about PPEs, you mentioned what's the reason for lack of PPEs. In my hospital in Chicago, PPEs are provided by the hospital. In Yemen or Syria or Gaza, you as a physician are required to purchase your own PPE because hospital is not able to provide it, not because of lack of resources, because of the poor governance that Radhya has mentioned and Hala has mentioned. Poor governance is one of the main diseases or most difficult diseases to treat in these countries, besides, of course, the war and the impact of the catastrophes. Also, because that you have many patients in the community who are coming to you as a physician who are not admitting that they have symptoms of COVID because of the stigma. Also, they do not want, they refuse to be tested, and that exposes physicians for patients who have COVID and they're not admitting this. And of course, we know that there are some cultural practices in some areas that are increasing the spread of COVID. In the United States, there were studies that showed that super spreading events are the main cause of spreading COVID nowadays in the United States. The same thing in the Middle East, especially in Syria, in Yemen, in Gaza, in the West Bank, in Al Khalil, which is the epicenter in the West Bank of COVID. Most of the patients who were infected because of weddings and funerals. And people are refusing to wear masks because of whatever reasons, because of they think that they are immune, because the first wave did not hit them hard, because they think that people in the Middle East are having mild strain of COVID for whatever reason, because also of the conspiracy theories. All of these things are feeding into this sentiment that we do not need to wear masks and there's no need for social distancing in some area, and that is feeding into the spread of COVID. In lack of testing, I mentioned Syria, 300 tests a day for a population of 18 million people. Definitely it is not enough. The government is not demanding for more tests, and the WHO is not providing more PCR machine or more testing kits to do more testing. If you have more testing, you will diagnose more, and patients will be quarantined because they are quarantine places, and physicians will be protected. One more thing I want to mention, that mentioned lack of PPEs in Yemen. I went to hospitals in Yemen, and these are main hospitals, public hospitals, treat thousands of patients. There's no soap. There's only one sink for the whole ward. So we're talking about not only shortage of PPEs, but shortage of disinfectant, of soap, of clean water in some of these hospitals that are treating tens of thousands of patients.
Thank you. There are a lot of questions here. I'm going to try to group a couple of them. But also maybe first a comment, because I'd like you to relate to this as well, is it appears there are some things that are policy related that could be done. There are some things that are very political in nature that may be very hard to address. And then there are clearly some supply and demand issues as well as cultural issues. So the three questions I have for you that have been asked by the participants. Number one is looking at the international community. Hala, you mentioned that there's not that much money coming. The humanitarian response appeal for COVID was some 10 point something billion, and there's only been about 1.9 billion. So it's very little, and obviously one of the reasons is it's a pandemic and everyone is taking care of their own countries in many ways. So one of the questions is, what can international community do more, taking into account the situation right now? It's not like it was in the past. There was a question from a medical student. What can medical students and public health people do, students, to get the word out? And then perhaps the last question, because I'm looking at the time, would be issues of quarantine and isolation. What is happening in your countries when because I've seen this across the board, when someone is even suspected or diagnosed with COVID, what happens? Are they isolated? Are they taken away from their families? And how are people responding to that? So I'm going to mix it up a bit, if you can try to be a bit quick, and I'll start with Hala and then go to Zaher and then Radhya.
I'll be very quick. For medical students, yes, very much your support is required, where UNFPA launched a virtual training program through webinars. And we started, and it proved to be successful. We need to learn what is the practice. If we cannot do this face-to-face, virtual, if we can do in these workshops that what we are doing now. Yes, our doctors, young doctors who are now coming out of universities and being pushed into the worlds of quarantine and isolation, they need some training. They need to learn how to wear the PPE properly. They need to understand IPC procedures very adequately, at least to protect themselves. In terms of what can the international community do? For us, people tell us, if we bring you money, what would you do? This is very difficult to answer. For the first time, it's difficult to answer because the size of the problem is so big. So in my approach, I would go to a community by community, enhance the work in a like a hospital by hospital to improve containment of COVID within the hospital, just so that for us, the priority is to protect the health provider. To be very honest, at this point, protecting the health provider is a main worry, because and without them, we cannot help the others. Quarantine for Iraq, it has been swinging between quarantine, not quarantine, do the sanctions, do the curfew, out of the curfew. Apparently, it has not helped much. I think we have passed the limit of quarantine. We have families of 20 people living in the same space. It is very difficult to maintain shielding or isolate those who have the incidents. It has proven to be very difficult. So I don't think it is practiced much, although it is still there, but I haven't seen it being implemented 100%. That's as far as I.
Thank you, Hala. Zaher?
I think one of the main points that maybe someone can get out of this seminar is the localization. You've mentioned that things are different from country to country, and it is different. COVID in Syria is different than COVID in Gaza, different than COVID in Yemen, than United States. So every country has its own problems and own challenges, and it's very important to listen to the voices from these countries and make sure that they affect our policies. So I think this is very important. There was this question about de-risking, which I've mentioned. So I'm from Syria originally. I have many friends who are in Syria, in Idlib, and also the rest of Syria, who are suffering right now because of COVID. If I want to help through MediGlobal to send, let's say, $100,000 so they can purchase PPEs and oxygen, it's impossible. Not because of the sanctions, but because banks, private banks, public banks have this de-risking process that I cannot wire to banks in Syria or Lebanon at this point. If I mention Syria in the memo, it will not go through. Yeah. So this issue has to be addressed, because humanitarian aid should be supported by every country, and all sanctions exempt humanitarian assistance. And that would be depriving people who are suffering because of the war, because of the catastrophes in these countries, and that would cause more death because of COVID, not because of the virus itself, but because of the lack of dealing with these challenges that are preventing aid to reach these countries. And last thing, for the medical students, I think it's very important to pay attention to the rest of the world. We are living in interconnected world, as we've seen in COVID. What happened in China affected every other country in the world, and it's affecting us. And what we will do in the United States will affect other countries also. So paying attention to what's happening in Yemen and Syria and Gaza and Iraq, making sure that we address these issues the same way that we addressed the Ebola epidemic, when there was this orchestrated international effort to address the epidemic, Ebola epidemic, and we were able to contain it and then stop it. We should do the same thing in countries that are fragile like Yemen and Syria, because if the healthcare system was overwhelmed and these countries collapse, then that will affect all countries around them, and that will lead to displacement, to refugee crisis, similar to what we have seen in Syria. And this is, by the way, this is reality. This is not imagination. It is happening right now because of COVID, and we have to pay attention to. It is connected to our health security, to our national security, and of course, it's the good thing to do.
Zaher, a question for you, and then to Radhya. The question for you is, and I wish I could have asked for Hala as well, is this idea of perception. So in Idlib, unlike, let's say, in the United States and other places, they've got a lot of other things on their mind, I imagine, right now with what's happening, the catastrophe and the horror there. How does COVID relate to being bombed, to having no house? How in your mind is this being the perception of COVID?
And in Idlib, I mean, people are, yeah. I mean, first of all, I was in Idlib and Gaza actually in February, right with the beginning of the epidemic, and people were taking it very seriously, actually more seriously than when I returned to the United States, and I've seen lack of interest in what's happening in the rest of the world. So first of all, people are paying attention. They're taking seriously, and they're trying to do with their limited resources. And this is something that we can learn from them, dealing with limited resources, because these countries, these healthcare workers have been dealing with limited resources for a long time. So they can actually teach us how to deal with the limited resources that we have. But at the same time, they need help. I mean, they need simple things like testing kits, PCR machines, PPEs that are available in the rest of the world. So there should be a better way, an easier way to get these things that are cheap and easy to get, and it will save plenty of lives to these countries that are suffering.
Thank you. Now for the last, we're going to go to Radhya. We have 2 to 3 minutes, and then I hand over to Michele. So Radhya, over to you, please.
Okay, Paul, you asked what can the international community do? And as I said, Yemen is a man-made crisis where even a very preventable disease like cholera, we couldn't face. The international community can push to stop the war in Yemen. This is the only solution for all the crises. It's not only COVID-19. And they can push their allies to stop the war in Yemen, to go to peace process instead of selling them weapons. Especially in Yemen, it's very possible. And humanitarian aid is very important, but it's only filling the gap. It will never solve the solution. The only solution is gonna stop the war. People want to have their life back, want to have their salaries back, and then they can have their health system also back. Otherwise, the situation will just continue as it is. One of the things we tried to push for during COVID-19 is to release more detainees, since the situation of detention facilities are in a very bad situation and could spread the COVID-19. And not too many work happened, but I wanted to end this positively, that today, finally, one of the very complicated cases was solved. The Baha'is, a group of Baha'is that were detained in Sana'a, has just released today after years of detention. And this is only because of the pressure. Pressure in Yemen can do miracles. And Yemen, as I always say, can be a very successful story if there is a political will.
That's a very nice way to end. Thank you. There are so many more questions and comments here. An hour is never enough. But thank you. I mean, I think you've all been very open, and we really appreciate that. There clearly are some things I think that can be done with no extra support, and there are a lot of things that could be done with support, but there are a lot of insurmountable issues, such as what you talked about, the de-risking the banking situation. That's been an issue for a long period of time. Counting on the international community right now, which is completely broken, to stop the wars in Syria and Yemen. Yes, that would be wonderful. I'm in a pessimistic mood like much of the world right now. But thank you, Radhya, for ending on a positive note that there was some, at least however minor, success now in Yemen with that particular group. So it's 14:55 and I'm handing it over to Michele. Thank you.
Yes, thank you to all the panelists. Really such a remarkable group of panelists, a rich discussion. And really, it's been a privilege to be in this virtual room with all of you and to hear this discussion. So thank you. On Thursday, I want to just let people listening about our next webinar on Thursday, August 6th at 1 p.m. Eastern time. Please join PHR for a conversation on COVID-19's impact on migrant encampments in Mexico. We'll have a particular focus on the Matamoros and Tijuana contexts. We'll have Dr. Ramanathan, who is one of our key PHR experts who has been doing remote evaluations in Matamoros. She will be moderating. We're thrilled to have as panelist Dr. Sondra Crosby, who also has been doing a lot of forensic documentation, Astrid Dominguez of the ACLU Border Rights Center, Jose Mares from Al Otro Lado, who is really providing a lot of help and assistance in Tijuana, and Helen Perry of the Global Response Management, who are providing, coordinating all the medical care and healthcare in the Matamoros encampments. Please do join us by registering at the link posted in the webinar chat. And again, thank you to all of you for being with us with this powerful, insightful, thought-provoking and challenging conversation today. We look forward to many more. Eid Mubarak for those who are observing tonight and tomorrow. Thank you. Bye-bye.